Good afternoon, everyone, and thank you for joining us to today's 2021 CAQH Index Findings webinar. We're excited to share the results of the report and our key findings. We have April Todd, SVP of Core and Exploration, Christine Bernaska, the Director of Research and Measurement, and Anna Simon, who's a data analyst presenting on today's call. Some logistics before we dive into our presentation. Today's session is being recorded. All attendees will receive a link to the recording in the next 1 to 2 business days after the webinar. You can also access the slides right now in the handout section of the GoToWebinar panel on your right. All attendee phones will be muted during the webinar. Throughout the session, you can communicate with us through the questions panel on your right. A run through of today's agenda. We'll kick things off with an overview of the 2021 CAQH Index before delving into some of the key findings from this year's report. Then we'll take a deep dive into specific transaction findings before ending today's call with an industry call to action, followed by a Q&A. And with that, I will turn things over to April.
Thanks, Daphne. And welcome everyone to our 2021 CAQH Index webinar. We're very excited to be able to share results of the survey this year. If you have noted and looked at the survey, this has been a very interesting year for the index as we are reporting out on some of the first findings we are seeing from the first year of the COVID pandemic. So if we could go to the next slide, please. As a brief overview of the index, the CAQH Index is an annual survey. This is our 9th annual report that we have done of the CAQH Index. And what the index does is it tracks adoption of administrative transactions across the industry. Particularly, it looks at the methods with which transactions are transmitted between health plans and providers for common business transactions along the administrative workflow. In doing this, we look at the cost and time associated with conducting those transactions. We look at whether they are done electronically using a HIPAA standard. We look at whether things are done partially electronically, and we also look at the spend and potential cost avoided of those transactions. We have set up our index every year to monitor these transactions, and we get advice and counsel from the CAQH, our CAQH Index Council. These are experts within the field that sit at various health plans within the government sector and various experts as well. We very much thank them for their expertise in helping us to conduct the index every year, as it is particularly important for us to monitor what is happening in the industry so that we can identify successes and also identify areas where some improvements can be made. We can go to the next slide, please. So what is tracked in the index? The index really tracks the entire healthcare administrative workflow. It starts from when a patient schedules a visit and when an individual looks to go to that visit and their eligibility is checked for what insurance they have that would pay for that visit. It goes all the way through when a patient sees a provider, when that patient might need a prior authorization for a particular service. It includes the submission of claims information from the provider to the health plan, all the way through the health plan adjudicating the claim, paying the claim, and providing additional information to the provider. We can go to the next slide, please. So in the index, every year, as I mentioned, we track a certain core number of transactions to track trends in those transactions over time. But we also ask supplemental questions every year, and that's guided from the feedback that we get from our advisory council. And this past year, we asked questions in 3 additional areas. One was around methods for exchanging clinical and administrative information related to prior authorization and claims. Secondly, we have started to ask questions around FHIR transactions for various use cases. We actually started asking questions about FHIR in the index prior to this past year, and we will continue to ask those questions going forward as this emerging technology becomes more used across the industry. And we have also asked questions around provider attribution, particularly related to value-based care. And value-based care is an additional area that we are continuing to ask further questions to understand how information is being tracked within the industry. We can go to the next slide, please. So there are various definitions that we use within the index that will be helpful to understand as we go into some more detailed description of the results. So first is transaction costs. I want to help folks understand what is included in costs when we report that. So whenever we talk about costs and savings estimates, this only accounts for the labor time that is required to conduct the transaction. It does not include pre-work or follow-up work or technology costs within those costs. We also commonly refer to transactions in terms of whether they are electronic, manual, or partially electronic. Electronic transactions are those that are fully automated, conducting using a HIPAA standard when there is a standard. If there's not a HIPAA standard, it would be what is the commonly used electronic format for that transaction. Manual transaction are those transactions that require end-to-end human interaction, such as using a telephone, fax, mail, email, really that require a human engagement in that transaction. A partially electronic transaction are transactions, for example, that incorporate the use of web portals or interactive voice response phone systems as part of the transaction. And on the next slide, we have some additional definitions around financial metrics that will be helpful for you all to understand as well. So cost savings opportunity, this is the savings associated with switching from manual or partially electronic transactions to fully electronic transactions. And this really is the gap in the cost of a manual transaction versus an electronic transaction. An additional metric is estimated spend. This is the amount of money spent by medical and dental plans and providers on conducting a transaction across all modes. So it's the full estimated spend. The electronic spend is the spend just associated with conducting electronic or fully automated transactions. The cost avoided, this is the amount of money that has already been saved by conducting transactions in a fully automated electronic way instead of manual or partially electronic. And so this shows what the cost avoided shows what the cost would have been if it was manual versus it now being electronic. So if we can go on to the next slide. This slide shows the various different transactions that we are reporting this year. For most transactions, we are able to report adoption, and that's the percentage of the industry where adoption is electronic. Also shows the cost per transaction, where we are able to report that, as well as time and cost savings opportunity. For most transactions, we are able to report all of those metrics. For some of those transactions, we are not able to report some of those metrics. It may be that we are not receiving yet enough data from either the medical or the dental industry, but we continue to ask about that and report that when we have enough sample size. If we can go to the next slide. So I want to summarize by talking a little bit about the data collection effort before we get into some of the detailed results. So the time frame of our data collection effort every year is from the end of June to the middle of September. And the reason for this is so that we are collecting information at the end of a typical claims runout cycle, which is about 6 months at the end of an annual year. The index comprises covered lives that comprise 61% of the medical industry. This is a significant increase from the prior year, and 44% of the dental industry covered lives. Our provider response has increased by 29%, which was a great increase this year, particularly during a year where we've had a lot of COVID challenges, particularly for providers. So I want to thank all of those providers for taking the time to respond to the index. We have a number of transactions that are reported every year by participants. We have very large volumes of those, and they're reported for 9 medical transactions and 7 dental transactions. And as I mentioned previously, we also ask a number of supplemental questions. We will be looking to report out on those supplemental questions through issue briefs throughout this year. And we hope you all have enjoyed the new design that we have this year. We are very excited about the new design and look forward to continuing to innovate on that into the future. So as we go into the next slide here, I'll hand it over to Christine and she'll talk through some of our key findings.
Great. Thanks, April, and to everyone for joining the call today. I'm now going to share the 2021 key findings with you. As we review these findings, keep in mind that this was an unprecedented year for the healthcare industry and the index. Federal and state policies aimed at curbing the spread of COVID and reducing strain placed on the healthcare system impacted the administrative workflow and processes. With this said, we saw that electronic adoption increased for the majority of all administrative transactions as health plans sought to further automate transactions to support staff working from home. Transaction volume decreased as utilization dropped. Surges in COVID and social distancing behaviors resulted in patients and providers postponing procedures and treatments. Efforts to minimize inpatient visits to lessen the burden on medical facilities treating COVID patients also impacted volume. And despite lower volumes, spending on administrative transactions increased for the medical industry as manual transactions became more expensive and time-consuming. New policies and regulations related to COVID and telemedicine often resulted in manual work that occurred outside the workflow. Conversely, spending for the dental industry decreased. Given the inpatient nature of many dental services, the use of telemedicine did not greatly impact dental plans and providers. And in some cases, lower utilization resulted in office closures. During this time, we also saw that cost savings opportunity for the medical industry increased as the gap in manual and electronic transactions increased. For some medical transactions, the cost of electronic transactions decreased as adoption and use of the HIPAA standards increased. And as I mentioned earlier, many manual transactions became more expensive as they required more intensive manual intervention from providers to ensure that new requirements and codes related to COVID and telemedicine were executed correctly and that patient medical files were current and accurate. Looking at the dental industry, we saw that cost savings opportunities decreased as the use of automated transactions increased. Next slide. We're now going to look at the data associated with the key findings. The next few slides present highlights related to adoption levels, transaction volumes, spend, and cost savings opportunities. As we walk through the findings, always keep in mind that the data is from 2020, the first year of COVID. And as mentioned on the previous slide, many contextual factors related to COVID impacted administrative processes. We'll start by looking at medical plan adoption. On this slide, you'll see that overall adoption increased for most medical transactions except for attachments, coordination of benefits, and claim status. Adoption increased the most for remittance advice at 7 percentage points, followed by eligibility and benefit verification, claim payment, and prior authorization, which all increased 5 percentage points. Among the medical transactions, prior authorization no longer has the lowest adoption as in previous years. For this report, attachments has the lowest adoption at 21%. Next slide. Switching to the dental industry, we see that adoption increased for all transactions. Adoption increased the most for eligibility and benefit verification at 7 percentage points, followed by claim payment and attachments, which both increased by 3 percentage points. Although claim payment had the second highest increase in adoption, it still remains the lowest among the dental transactions reported. Next slide. This slide shows that overall transaction volume decreased for both industries due to lower utilization during COVID. Medical volume decreased by 11% and dental volume decreased by 3%. It's important to note that despite the drop in overall transaction volume, the proportion of electronic transactions continues to increase and accounts for the highest percentage of total volume for both the medical and dental industries at 81% and 48% respectively. Next slide. On this slide, we see that spending related to administrative transactions varied for the medical and dental industries. Although we saw a decrease in overall medical transaction volume and an increase in electronic adoption, medical spend increased 12% to $37.4 billion, as some transactions required more intensive manual intervention from providers. In comparison, dental spend decreased 23% to $4.4 billion as utilization dropped, adoption increased, and cost decreased or remained stable for most transactions. Next slide. We are now going to dig deeper into the medical industry to see what is driving spend. Based on the reported data, the medical industry spent an estimated $37 billion conducting the listed transactions. This amount is up about $4 billion from last report. Of the $37 billion, eligibility and benefit verification continues to account for the greatest portion of the total annual medical spend at 49%, followed by claim submission, which accounts for 16% of the total annual medical spend. The increase in spending for eligibility and benefits can be attributed to a significant increase in provider costs and time to conduct manual eligibility and benefit verification checks. The rise in telemedicine and complex COVID cases resulted in calls, faxes, and emails. It is worth noting that the largest decrease in spend from last year is for attachments, while the largest increase in spend from last year is for claims payment. Focusing on costs avoided, we see that the medical industry has avoided spending $161 billion through automation, up from $117 billion last year. Next slide, please. Looking at the dental industry, we see that dental spending dropped from $5.7 billion to $4.4 billion. Of the $4.4 billion spent on conducting the listed transactions, similar to the medical industry, eligibility and benefit verification continues to account for the largest portion of the total annual dental spend at 28%, followed by claim status inquiry and remittance advice, which both account for 20% of the total annual dental spend. Despite accounting for the largest portion of the total annual spend, dental spending on eligibility and benefit verifications declined as overall volume decreased and cost per transaction remained relatively stable. I'll note that the largest drop in spend from last year was for remittance advice, followed by claims payment. Focusing on costs avoided, we see that the dental industry avoided $4.4 billion through automation. Next slide, please. On this slide, we see that the cost savings opportunity continues to increase for the medical industry and decrease for the dental industry. The cost savings opportunity for the medical industry increased 32% to $17.6 billion as the gap widens between electronic and manual transaction costs, resulting in greater savings opportunities. Conversely, the dental cost savings opportunity declined 13% to $2.6 billion as dental adoption increased and cost remained stable or decreased. Next slide. The figure on this slide presents the average per transaction cost for medical, electronic, and manual transactions. As you can see, the gap between electronic and manual cost per transaction continues to widen, resulting in greater cost savings opportunity. For this report, the average cost to conduct a manual transaction increased as new and changing requirements and policies related to telemedicine introduced additional and varied administrative complexities, often resulting in costly and timely manual work. Next slide, please. We're now going to look more closely at what is driving the cost savings opportunity for the medical industry. There's a lot of data in this table, so I'm going to highlight some key findings. Looking at the average cost to conduct each transaction, we see that the biggest cost savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. On average, the medical industry could save $16.65 per claim status inquiry by conducting an electronic inquiry as opposed to a manual inquiry. Similarly, the industry could save about $15 per eligibility and benefit verification by conducting a verification electronically as opposed to manually. Looking across the transactions reported, we found that on average, each manual transaction costs the industry $7.28 more than each electronic transaction. And these savings add up. And for a single patient encounter, the medical industry could save over $58 if all of the reported transactions were conducted electronically. The cost savings opportunity is larger for providers at almost $42, while plans could save about $16 per patient encounter. There are also cost savings opportunities associated with moving from portal use to fully electronic transactions. On average, the industry could save over $6 by conducting a prior authorization using the HIPAA standard as opposed to via a portal. Similarly, the industry could save slightly over $3 by conducting a fully electronic claims status inquiry as opposed to one using a portal. Next slide, please. We're now going to look more closely at what is driving the savings opportunity for the dental industry. This table mimics the table we saw for the medical industry with just fewer transactions. So looking at the average cost to conduct each transaction, we see that the biggest cost savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. On average, the dental industry could save $10.76 per claim status inquiry by conducting an electronic inquiry as opposed to a manual inquiry via phone, fax, or email. Similarly, the industry could save about $9 per eligibility and benefit verification check by conducting a verification check electronically as opposed to manually. Looking across the transactions reported, we found that on average, each manual transaction costs the dental industry $5.11 more than each electronic transaction. And again, these savings add up. And for a single patient encounter, the dental industry could save over $25 if all the reported transactions were conducted electronically. Similar to the medical industry, the cost savings opportunity is larger for dental providers at $18, while dental plans could save about $7 per patient encounter. Looking at the cost savings associated with moving from portal use to fully electronic transactions, we see that on average, the industry could save slightly over $3 per transaction by conducting an eligibility and benefit check using the HIPAA standard as opposed to via a portal. Similarly, the industry could save about $2 by conducting a fully electronic claim status inquiry as opposed to one using a portal. Next slide, please.
What do you want to play?
In addition to estimating cost savings opportunities, we are also able to estimate time savings opportunities by moving from manual to fully electronic transactions. Looking at the medical industry, we found that on average, providers spend 12 more minutes conducting manual transactions than electronic transactions. For patients requiring all 7 medical transactions, a provider could save, on average, almost an hour and a half by conducting all the transactions electronically instead of manually. Focusing on the individual transactions, we saw that the highest time savings opportunity is for claim status inquiry. On average, a manual claim status inquiry required 25 minutes to complete, while an electronic inquiry required 3 minutes to complete. Providers could save 22 minutes by conducting an inquiry using the HIPAA standard as opposed to calling, emailing, or faxing. Just as there are cost savings opportunities associated with switching from portals to fully electronic transactions, there are also time savings opportunities. On average, a medical provider could save 25 minutes by conducting the reported transactions using the HIPAA standard as opposed to via a portal. Next slide, please. Moving on to the dental industry, we found that on average, dental providers spend 7 minutes more conducting manual transactions compared to fully electronic transactions. For patients requiring all 5 dental transactions, a provider could save, on average, 33 minutes by conducting the transactions electronically instead of manually. Focusing on the individual transactions, similar to the medical industry, we saw that the highest time savings opportunity is for claim status inquiry. On average, a manual claim status inquiry required 17 minutes to complete, while an electronic inquiry required 3 minutes to complete. Dental providers could save 14 minutes by conducting an inquiry using the HIPAA standard as opposed to calling, emailing, or faxing. By switching from portal use to fully electronic transactions, a dental provider could save, on average, 13 minutes. Well, that concludes my presentation of the key findings. I know I shared a lot of information with you. If you have any questions, please feel free to ask them in the question panel or email us after the presentation at explorations@caqh.org. I'm now going to turn the presentation over to Anna Simon, the data analyst on the index. She's going to dig deeper into the individual transactions along the administrative workflow. Anna?
Thanks, Christine, and to everyone for joining us today. As Christine mentioned, I'm going to present findings for the transactions studied in this year's index. For each transaction, I will share trends in adoption and volume, and where possible, provide some context around the findings. We will start with the eligibility and benefit verification transaction. Next slide, please. Looking at adoption, we see that electronic adoption increased for both the medical and dental industries. Medical adoption for eligibility and benefit verifications increased 5 percentage points after remaining stable the previous year. For the dental industry, adoption increased 7 percentage points. This is the highest increase among the dental transactions. Next slide, please. On this slide, you will see that overall volume of eligibility and benefit verification transactions decreased for both the medical and dental industries. Medical volume dropped by 18% and dental volume dropped by 5%. Despite the decrease in medical volume, the spending associated with eligibility and benefit verification increased 16% and remains the highest among the transactions, accounting for almost half, or $18.3 billion of the total annual medical spend. The medical cost savings opportunity also increased 45% to $9.8 billion. This increase is due to new codes and plan requirements associated with telemedicine and COVID-19, and also coverage changes associated with job losses, which prompted medical providers to place calls to health plans to discuss and verify varying and sometimes complex benefit situations, which led to an increase in manual costs. Next slide, please. Moving on to prior authorization, we see that electronic adoption continues to increase and increased 5 percentage points from the previous year. Next slide, please. Looking at the number of prior authorizations conducted, we see that overall volume decreased 23%. This is due in part to requirements around prior authorization being suspended or waived during the early months of the pandemic to help reduce administrative burden on strained staff and also to provide timelier patient care. Next slide. Focusing on adoption for both the medical and dental industries, Electronic claim submission increased slightly and remains one of the highest levels of electronic adoption at 97% for the medical industry and 84% for the dental industry. Next slide. On this slide, we see that claim submission volume remained fairly stable for the medical industry and declined 18% for the dental industry. It's interesting to note that based on research we conducted last year, we found that in the early months of the pandemic, medical claim submission volume declined by 9% as providers and patients followed social distancing guidelines, resulting in lower healthcare utilization. However, as the year progressed, medical claim submission volume stabilized as telehealth services expanded for non-emergency cases. Telehealth was not as prominent in the dental community, given the in-person nature of many dental services. Next slide, please. When discussing electronic adoption of attachments, it is important to note that an electronic transaction standard for attachments has yet to be federally mandated by HHS, which has impacted adoption. Plans, providers, and vendors have been reluctant to create automated solutions without federal guidance and industry support. This has led to incomplete solutions and manual workarounds, as evident by the low adoption on both industries. Next slide. Turning to the number of attachments conducted, we saw that volume decreased for the medical industry and increased for the dental industry. Fewer attachments were exchanged between medical plans and providers as fewer prior authorizations were conducted. The slight increase in the number of dental attachments conducted was driven by an increase in the use of electronic attachments. This is an encouraging sign for the dental industry. Next slide, please. For the first time this year, we are able to report on acknowledgements for dental industry and begin trending acknowledgements for the medical industry. As a reminder, the index measures the number of 999 and 277 CA transactions. The 999 acknowledges all X12 transactions submitted in batch mode, while the 277 CA acknowledges receipt of a claim by a plan or vendor. Given the majority of health plan systems auto-generate a confirmation response after receiving information from a provider or a clearinghouse, plan adoption is almost 100% and was not impacted by processes and procedures implemented related to COVID-19. Next slide. This slide shows that electronic adoption of coordination of benefits decreased 2 percentage points for the medical industry. This drop occurred as complexities in coverage during COVID-19 resulted in more manual interactions. Next slide, please. On this slide, we see that overall volume decreased 13%, driven by a drop in the use of electronic coordination of benefits. It's important to note that although fewer coordination of benefits were conducted, the cost to conduct a COB increased for all modes as health plans performed additional steps to identify individual coverage information. Health plans and providers were mindful that job losses and changes that occurred during the pandemic often resulted in coverage changing multiple times within the year. Because of this, staff often had to place phone calls and perform manual tasks to determine payment responsibilities. Next slide, please. Moving on to claim status inquiry, we found that claim status inquiry is one of the few transactions that experienced a drop in electronic adoption for medical plans as new policies and guidelines related to telemedicine and COVID-19 resulted in providers using more manual methods to inquire about the status of a claim. In comparison, electronic adoption increased for dental plans. Next slide, please. Looking at the number of claim status inquiries conducted, we see that overall volume decreased 10% for the medical industry. This was due to a decrease in utilization and temporary closings of call centers during the peak of the pandemic. For the dental industry, volume remained fairly stable as dental providers indicated that they checked the status of outstanding claims while offices were closed and utilization was low. Next slide. Moving on to claim payment. Once services have been rendered and a claim has been validated and approved, a payment is typically issued. Looking at the adoption of electronic payments, we found that adoption continued to increase for both the medical and dental industries, as lower utilization resulted in providers seeking to be paid more quickly through electronic methods. Next slide. As opposed to other transactions, for the medical industry, claim payment experienced a significant increase in the overall volume to 60%. Digging into this, we heard that during the early months of the pandemic, when healthcare utilization was low, medical providers spent time reconciling past due payments. One health plan indicated that the increase in volume was due largely to plans reimbursing claims that were unsettled before COVID-19. As telemedicine services became available and popular, providers also billed more regularly for telemedicine visits to help offset the loss of revenue experienced early in the pandemic, and plans paid more quickly versus bundling payments. In comparison, the dental industry experienced the largest decrease in total volume for claim payment and claim submission, around 18%, due to fewer patient visits during COVID-19. Next slide. And lastly, we will talk about remittance advice, the final transaction in the administrative workflow. On this slide, we see that for the medical industry, adoption of electronic remittance advice increased 7 percentage points, while it remains stable for the dental industry. Next slide. Focusing on volume, we see that fewer remittance advices were conducted in the medical industry as fewer services were performed and more remittance advices were transmitted electronically in batches as a single transaction. For the dental industry, remittance advice volume dropped slightly. Many dental providers indicated that they pulled remittance advices as they reviewed and reconciled outstanding accounts payable and receivable when office visits were low. In addition, remittance advices were automatically pulled for DSOs as part of their reconciliation process. In these instances, remittance advices were not linked to new claims or payments, but to efforts associated with balancing the accounts. Well, that concludes my discussion of the detailed findings related to the transactions studied. For more information on the individual transactions, I encourage you to look at the 2021 index report posted on the CAQH website. I will now turn the presentation back to April to talk about actions that the industry can consider to help maintain and improve on the achievements that we just discussed. April?
Thank you, Anna. So as we are looking to conclude our call here and go into questions, wanted to highlight a few things that we found as important this year that the industry can build on. One is, as we've mentioned a number of times, one of the silver linings of the pandemic is that we have seen an increase in automation. And that was often due to necessity, as there were staff that was working from home, and some of the more manual administrative processes weren't available or easy to use during this period of time. And so we did see increases in automation. And so, as we look to go to the future, capitalizing and expanding on these efforts, as you've seen through the results, can really help to reduce spend and time spent on administrative activities. And what we've also seen is that, these administrative activities that do go to manual, they can get quite complex and become very expensive. And so it also highlights the need to address those more complex cases and find where there are automation options to help reduce some of those instances. We've also seen during the pandemic a drastic rise in the use of telemedicine, and also some confusion that has come with that. And so there are some needs for standards and operating rules to look to address telemedicine more effectively. I would say here, one of the things that CAQH Core has been doing is looking to help address the use of telemedicine and eligibility and benefits. And so hopefully that's something that will be available to the industry soon to use. And then lastly, also wanted to really highlight how just general improvements in interoperability across systems can really help during times of crisis, and how there are a number of industry initiatives that are in play right now that could really help to improve that interoperability. And so, as we've seen during the pandemic, there are new processes and workflows that needed to be developed to address some new business needs, and with the tools that we have with interoperability today and those that are emerging, there's definitely things there that can be improved upon to help improve automation into the future. So with that, we have some time left on the call for questions, and we have already been getting in a number of questions. So I am going to start at the top here. I am almost positive we are not going to get through all of these questions, but we will look to follow up on some of these questions that we don't get to and make them available on our website. So first question I have come in is you described that you have been asking about fire use cases. Can you describe what those are and whether any of them are included in the transaction slides? So Christine, can I hand that over to you?
Yes, you can. I'm pulling up the survey right now. I will be honest, I don't know them off the top of my head, but what I can say is that they are not included in the transactions right now. And if you give me a second, I apologize. So the use cases that we asked about in the 2021 survey were the payer-to-payer data exchange, the documentation requirements lookup service, API, the DRLS, and the prior authorization support, the PAS. And for each of those use cases, we asked about the readiness of the organization related to those use cases. So were they planning future testing, testing internally, piloting with trading partners, conducting production level data exchanges, or just are unaware of what's taking place. And then we asked for the associated implementation costs. And for that, we asked a range of costs with the thought that an individual may not know exactly the entire cost that went into implementing the use cases.
Thank you, Christine.
Sure.
So the next one I'm seeing here is asking whether there are any regulations forthcoming around attachments. And I can take that one. We are hopeful that there are forthcoming regulations around attachments. Last year, actually in the Fall Unified Agenda that came out from HHS, there was mention that there was an attachment regulation likely coming and potentially this month in February. So we are on the lookout for that, and hopefully there will be one soon. Let's see. The next one here, Christine, I'm going to hand this one over to you as well. This is related to the eligibility and benefit transaction. And there's a question around whether the survey breaks out the number of transactions and costs associated with checking eligibility and benefit transactions via a payer web portal versus the HIPAA standard. And whether, you know, how is that calculated, and do we capture that information?
Sure. So for eligibility and benefit verification, similar to the other transactions that we asked about, we ask respondents to bucket volumes, times, and costs into whether the transaction is conducted using the HIPAA standard via a portal or IVR. So if a respondent is using a payer portal, that would be considered a partially electronic transaction, or whether they're conducting it manually. And then for the plans, we look at the adoption associated with those modes. And then we ask for plans and providers the cost associated with conducting a transaction using those modes.
Okay. Next question is somewhat similar. It says, is there a distinction between how you count a payer portal for one payer versus a multi-payer vendor portal for any of the transactions?
No, we currently, when we are looking at the individual transactions, we do not separate whether it is multiple portals or one portal.
Okay. Let's see here. Do you expect, here's another question, do you expect per cost claim of manual claims to drop back to pre-COVID levels as telemedicine becomes more established? I can start on that, and Christine, if you want to add in, I think that's one of the interesting things that we're looking to track in the next couple of years of the index, is to see how that shifts. We would hope that cost does go down as telemedicine, as standards and operating rules and more standardization on telemedicine becomes used, but that's definitely something that we are tracking and looking forward to report on in the next few years. I don't know, Christine, if there's anything else you wanted to add on that.
No, but I echo. I think trying to standardize and get some requirements and rules around telemedicine will be very helpful, because as we heard from providers right now, there's varied and changing standards, codes, et cetera, around it. So they have a very difficult time determining which code to use and when. So I think that definitely was driving the manual cost up. So if we can get some standardization and consistency around those codes, I think then we will see manual costs eventually decrease.
Okay, great. Let's see here. Next question. Is telemedicine specifically tracked by the index? Any more detail you can share on telemedicine? Christine, do you maybe want to take that one?
Sure. So currently, it's a great question. We do not track telemedicine separately. We know that telemedicine can impact the majority of the transactions that we're studying. But currently, we do not track that separately. We do hope, though, that in the future, we can begin tracking telemedicine in the index and begin trending it. And I know, April, you specifically talked, I think it was earlier, about eligibility and benefit and telemedicine, and how CORE is working on incorporating telemedicine into some updates related to the eligibility and benefit transaction.
Yeah. The other thing I would add there as well is when we do the surveys every year of plans and providers to collect information for the index, we also follow up with more detailed interviews to ask about the trends and to help understand what's going on with the trends. And what we heard consistently this year is that telemedicine was a big factor in a number of the transactions. And so in addition to the numeric results that we get, we are able to qualify those results with some of the qualitative information that we collect as well. Christine, another question here. It looks like there's dental and medical information provided. Are you also looking to continue to report on pharmacy and is vision potentially in the future?
Yeah, great question. So currently we do not collect data related to vision. In the future, I think we'd love to. As you alluded to, we have started to collect information related to pharmacy services. We've been working with PBMs to gather information related to some of the NCPDP standards, and we have started to expand the pharmacy transaction data collection effort into providers as well as plans and other pharmacies overall. With all that being said, we have started and created a pharmacy services index council specifically related to the pharmacy industry. And the members on this council represent PBMs, providers, health plans, and pharmacies. So in the future, we do hope to expand on the pharmacy services that we can report on in the transactions and data collection effort overall.
Great. There's also a question in here, another one around attachments, and this one is around timing. You mentioned that an attachments regulation might be coming out this year. When would that be effective? I can take that one. So if an attachments regulation comes out from CMS this year, essentially how that process works is that there is a proposed rule that is put out. That rule typically has 60 days for public comment. And then CMS takes those comments, evaluates them, and would come up with a final rule. Under HIPAA and under the process for incorporating things into HIPAA and for administrative standards, there is a provision in there that those requirements for any transaction, if it happen to be attachments, is 25 months for implementation after a final rule is effective. That. And I think we maybe have time for one more question here. As I mentioned before, we have more than we are able to answer. We will look at these and try to summarize them on our website. So one last question here. What are the things, Christine, that you would say have been most unique about this year in terms of transactions related to COVID impact?
Yeah, I've actually spent a lot of time thinking about this, especially as we were writing the report and creating the slides. To me, what really stood out was that, and this was mentioned throughout the presentation, was that we did see an increase in adoption. And, as April mentioned, we do some qualitative research and talk to the plans and providers about this. And this was due to people working from home and relying more on automated processes. Call centers, we found out in some cases, were closed or shut down temporarily. And oftentimes people didn't have access to faxes or some of the more manual tools that were used to complete some of these transactions. So that definitely stood out to me. The lower transaction volume due to lower utilization. I think that definitely stood out. What was particularly interesting when I looked at spending was that we saw variation between the medical and dental industry. So the medical spending and savings opportunity increased despite that lower volume. And that was mainly due to manual transactions really becoming much more expensive. And we talked about this throughout the presentation, but we heard from plans and providers that due to new requirements and policies and codes, oftentimes plans and providers were on the phone trying to figure out, where they should code a telemedicine visit, perhaps something related to COVID. They also, when they were checking to see if a patient was eligible for telemedicine or for anything, COVID related, there were also phone calls, coordination of benefits. As Anna mentioned, people changed jobs quite frequently throughout the pandemic and or loss of jobs, switching plans, switching enrollment status. So that resulted in phone calls. And so these manual processes became more expensive. And at the same time, because automation was increasing, many electronic transactions became less expensive. So that gap definitely widened, which increased the savings opportunity. And then just on the dental side, we just saw a decrease in spend and savings, and that was basically due to just utilization decreasing so much.
Thank you, Christine, and thank you all for joining us today. We are actually a little over our time. We thank you for joining us, and I will hand it back over to Daphne to close us out.
Thanks, April, and thanks all of you guys for tuning in. You can download the CAQH index now on our website. It's also available in the handout section. As a reminder, a recording of this webinar will be available within the next couple of business days, and it will also be posted on our site. Thank you so much for joining us. Have a good afternoon.